Ma'am, I'm starting.
I think we should start, Saumyta, if you're ready.
Yes, ma'am. A very good evening. Today
Hello?
Yes, ma'am.
Hello?
I'm audible, ma'am. Hello.
Saumyta?
I'm audible, ma'am.
Yeah.
Somebody else.
Dr. Raina Rana, can you just mute yourself?
A very good evening.
I would request all of one sec, Saumyta. I would request all of you all to please mute yourself before we start.
Dr. Raina Rana, who is this, please? Whoever is this, please mute. And you can continue watching that movie. It's a nice movie. Please go ahead. Okay. Yeah.
A very good evening. Today I am presenting poorly differentiated thyroid cancer. Poorly differentiated thyroid cancer as a new clinico-pathological entity was given by Sakamoto et al. Aggressive subgroups of thyroid cancer was introduced by Langhans in 1907. Wukarende Struma, he has termed. Carcinaccio et al. In 1984 described their version of poorly differentiated thyroid cancer. Along with the architectural changes like solid cluster or insular growth pattern, perithelioma-like structures, they all are included along with mitotic rate and necrotic foci in the diagnosis of poorly differentiated thyroid cancer. So this is the normal picture of thyroid cells, in which we can see follicular cells along with blood vessels, some parafollicular cells, and colloid is filled in between. And this Wukrende stroma, term given by Langhans in 1907, which shows very follicular cells along with fibrovascular pattern, stromal pattern. And this is insular carcinoma given by Karkangui, Zampi and Rosai in 1984. WHO 2022 have given the follicular derived carcinomas as a high grade, and which they have in high grade they have said invasive follicular carcinoma of thyroid follicular cells. High grade features defined by mitotic count and tumor necrosis, and there is no anaplastic histology in it. So basically poorly differentiated thyroid cancers are follicular cell origin showing histological and prognostic features intermediate between well differentiated thyroid carcinoma and anaplastic carcinoma. So what are the characteristics of poorly differentiated thyroid cancer? It accounts for very less percentage among all thyroid carcinoma, that is 3 to 5%, and the variation in the incidence mainly due to environmental factors and differences in the histopathological interpretation. The mean age which is between 55 to 63 years, little bit elderly as other cancers of thyroid, and slight female preponderance as other thyroid cancers. The 5-year, 10-year and 15-year survival rates of poorly differentiated thyroid cancer patients 50 to 85% and 34 to 50% in 10-year and 0% in 15-year survival. So in spite of being incidence is very less, but relatively higher number of deaths to the thyroid carcinoma attributable to poorly differentiated type. So current nomenclature WHO classification, thyroid neoplasm includes the criteria of both morphological as well as mitotic rate, and management of these rare and aggressive subgroup malignancies sometimes very challenging for the clinicians because there is no definitive approach how to treat them. That's why we are discussing this topic today. Diagnosis: lump in neck with rapid volume of increase in size, most common symptom and sign of the poorly differentiated thyroid cancer. Along with there are symptoms like hoarseness of voice, dyspnea, dysphagia, but it is not a symptom in which we can accurately diagnose. For accurately diagnosis, we need a tissue biopsy. FNAC is also not very sensitive for diagnosing. Definitive diagnosis made by histopathology, ISC, and molecular characteristics. So, what is the optimal imaging for the suspect or diagnosed poorly differentiated thyroid cancer? For all thyroid cancer, as usually we do USG. So, comparative study done by Han et al. Which suggested the USG findings of PDTC and anaplastic thyroid carcinoma.
Wait a minute. Sorry, Saumyta. Wait a minute. Who is this iPhone 9? Please, could you please mute yourself? See, it is really rude if you all don't mute and when the speaker is speaking. At least have some etiquette. iPhone 9. Who is iPhone 9? Please, this is... Sorry, Saumyta, go ahead.
So dominant findings in the poorly differentiated thyroid cancer, heterogeneous echogenicity, and almost 2/3 of the 63% of the poorly differentiated thyroid cancer retain circumscribed margins. In anaplastic carcinoma, only 1/3 are the well circumscribed. So normal features are relatively low echo, heterogeneous echo mass with a circumscribed margin, and oval to round shape on sonography. The incidence of lymph nodal mets in poorly differentiated thyroid cancer is 30 to 59%, extrathyroidal extension is 50 to 75%, and distant metastasis is 13 to 33%. If there is a suspicion of advanced disease on USG is raised, then axial imaging can help, like CT and MRI, and for distant metastatic screening can also be useful for such type of patients. And suspicion of ETE, extrathyroidal extension, esophagoscopy, transesophageal ultrasound may also be required. So, what is the role of nuclear medicine in the poorly differentiated thyroid cancer? Because these are the aggressive cancer, so we have to look for the distant mets. Iodine 131 whole body scan and 18 FDG PET scan are offered for this patient along with the molecular and cellular level, because based on metabolism and biochemical processes little bit complicated. In this there is a dedifferentiation of tumor, consequent deficiency of sodium iodine importer trafficking. Negative iodine 131 scan is common. So we can detect this on 18 FDG PET scan. This is one flip-flop phenomena which we usually see in these patients, in which 70% of patients, this is common in 70% of the poorly differentiated thyroid cancer. And at 18 FDG PET scan is also useful for planning for EBRT, and the treatment volume to be given on the FDG avid disease is recognized as a single risk factor for predicting survival. Molecular imaging PET scan play a dual role of screening of distant metastasis and disease biology in the case of poorly differentiated thyroid cancer. Theoretically, the thyroid tumors dedifferentiate and less expression of sodium iodine importer and more gain in FDG avidity. Now, after there are different patterns of tumoral uptakes can be seen on FDG gallium dotatate and gallium PSMA PET CT, but among them most sensitive is 18 FDG PET scan only. So this is a picture of a 60-year-old woman in which this picture is showing the flip-flop phenomena. What is flip-flop phenomena? In this what we can see, this is the disease which is not able to see in iodine scan, but we can see in the PET scan. Histological features of poorly differentiated carcinoma are solid trabecular insular growth pattern, necrosis, capsular invasion, vascular invasion. All of the above are present, then poorly differentiated we can say. So WHO classification, this table is based on 2017 WHO classification, in which we can see the poorly differentiated carcinoma, morphology wise they are saying invasion, mitosis more than 3, necrosis and convoluted nuclei. And what are the molecular markers present? RAS, TERT promoter, T53 and PIK3K. in which in future slides we will see ki RAS and BRAF and TERT. TERT is the most common, and we frequently see RAS and BRAF. So this is the WHO 22 thyroid neoplasm, in which we can see malignant thyroid neoplasm, follicular cells, and oncocytic. Hurther cell is replaced by oncocytic, PTC. And poorly differentiated thyroid cancer is a different entity, and one new entity has been integrated in this. Is a differentiated high-grade thyroid cancer, and this is the most important pathological entity which we have to be usually distinguished on the histopathology, because there is very less distinguished features in both of them. And another in last anaplastic thyroid cancer, but in this high grade type of entity there should be no anaplastic in pathology. So this is the criteria which WHO 2022 follows. They divided this high grade into two, poorly differentiated and high grade. In Turin criteria they have used for saying what is poorly differentiated thyroid cancer. What is poor Turin criteria? Growth pattern, solid, trabecular, insular required. Nuclear cytology, there should be no features of PTC. And tumor necrosis, among the following features, 3 features, one of the should be present. Mitotic count more than 3 per 2 meters square. Tumor necrosis or convoluted nuclei. What is the difference between these? PTC can be present. Any of the histology of PTC can be present, and follicular, papillary and solid growth pattern is there. And mitotic count, it was 3 in PTC, poorly differentiated, but it is 5 plus 2 meters square in differentiated high grade thyroid cancer. But anaplastic features is absent in both variety. So this is the distinguishing feature in this. So this is a picture of insular pattern of the poorly differentiated thyroid cancer with fibrovascular stroma, and the pathological picture, this arrow is showing necrosis. Malignant thyroid tumor of epithelial cell. So in this way they have made one flow chart so that we can easily reach to the diagnosis. If STI pattern is present or absent. If it is present, then typical PTC nuclei is present or not. If not present, then we will look for it is more than 5 or less, more than 3 mitosis, whatever. If more than 3 mitosis and convoluted nuclear necrosis is present, then we will reach to poorly differentiated carcinoma. So histopathological wise, this is the conclusion, which is one paper has been described. In this we can conclude that Ki67 is not required to discriminate them. This mitotic count is main important feature to separate poorly differentiated from differentiated high grade carcinoma. So same previously what this high grade differentiated thyroid cancer, what criteria they have taken. This is the MSK criteria. Previously they were using both criteria to identify poorly differentiated thyroid cancer, but in WHO 2017 and 2022 both used Turin criteria for diagnosing poorly differentiated thyroid cancer. So this is a high grade differentiated thyroid cancer. Follow what we see in the now in WHO MSK criteria they use for the high grade differentiated thyroid cancer, and Turin criteria they use for poorly differentiated thyroid cancer. And what is the difference between among mutation? That poorly differentiated thyroid cancer, RAS is the most common, more common driver mutation, but in differentiated high grade thyroid cancer, BRAF V600E is the majority of the driver mutation. And this is the follicular derived carcinoma. They have different subtypes. So we can see RAS is 44% in poorly differentiated and differentiated high grade, 81% BRAF V600E, and TERT is exactly common in both. The higher frequency of TP353 and TERT promoter mutation in poorly differentiated thyroid cancer as compared to rest of the differentiated thyroid cancer. And although the only 15% of the patient present with the metastatic at the presentation, but distant mets in subsequent time occur in 37 to 85% of the patient, and 60% of patients are dying to the distant disease in the course of time. So this is the main, more patients are dying due to the disease, so we need more focus how to manage such type of pathology. WHO classification, as I already told, the poorly differentiated thyroid cancer as a separate entity came as a 2004. Then current classifying as a high-grade follicular derived neoplasm having intermediate prognosis, and Turin criteria is used by both WHO 2017 and 22, and MSK criteria is now used for differentiated high-grade thyroid cancer. To differentiate between this, there is no Ki67 based labeling index cutoff, and poorly differentiated thyroid presented at a younger age with larger tumor and multifocal size and lesser metastasis compared to differentiated high-grade thyroid cancer. And poorly differentiated component, what they mean to say, if a well differentiated thyroid cancer is having even low as 10% poorly differentiated component, still their survival is lower or poorer as compared to other group. And few studies reveal that 75% of the poorly differentiated component in well differentiated cancer associated poor survival. So there is a two school of thoughts, but few studies says even 10% of their component is also harmful for the patient. So this is the American Society one his survival flow chart, in which we can see that the follicular cells, if necrosis is present, then is a poor survival. Is a one scoring system is there of nuclear score, necrosis score, in which they say if necrosis is present, that group survive less, and that is statistically significant also. This trabecular solid insular pattern has a poorer survival as compared to F follicular and PTC. And then Turin proposal was there, as we can say that PTC and poorly differentiated has lesser lower survival, overall survival also we can say. If necrosis is there, then is also lower survival, and if mitotic count more than 3, then also lower survival. These all criteria have taken and formed Turin criteria. So there is a study, Lee et al. 2016, it has been done to compare the outcomes of the different pathological forms of thyroid cancer, in which they have seen if poorly differentiated thyroid cancer have lower survival rate with differentiated thyroid cancer with anaplastic foci, and ATC have lowest survival. So these are the one of the studies, Sanders et al., which have evidence-based review they have done for poorly differentiated thyroid cancer, in which they have included these 4 studies. In all, we can see that the poorly differentiated thyroid cancer have lower survival as compared to well differentiated thyroid cancer. So what is the role of immunohistochemistry to differentiate the poorly differentiated thyroid cancer from other diagnoses? PDTC confused with the medullary thyroid cancer or anaplastic thyroid cancer. And from medullary thyroid cancer, they can be separated from calcitonin, chromogranin and synaptophysin. They all negative in poorly differentiated. And PDTC positive for thyroglobulin and TTF1, whereas anaplastic thyroid cancer lack immunostaining or focally positive. So finally, what I concluded from this table, we can see that from medullary thyroid cancer, we can separate is from calcitonin, chromogranin, synaptophysin. But thyroglobulin is positive in poorly differentiated thyroid cancer, which is absent in medullary thyroid cancer. And TTF1, from TTF1 we can distinguish it from anaplastic thyroid cancer, because TTF1 is positive in poorly differentiated thyroid cancer and negative in anaplastic thyroid cancer. and PAX8 is positive except in medullary thyroid cancer. There are some epigenetic deregulations, expression of MIR23B and MIR150, both well-known tumor-associated miRNAs, seems to play a role in poorly differentiated thyroid cancer, and they are also suitable for predicting patient outcome also. So these are the old which we were used to read from our PG days, that normal follicular cells are common for all follicular cell origin cancers, differentiated thyroid cancers. If RAS mutation and PTEN are present, then occal PTC can be converted into PTC, and if there is more mutation, then it can convert into poorly differentiated thyroid cancer. Same it follows for follicular adenoma, follicular thyroid, and P53 mutation may lead to the anaplastic thyroid cancer, which now in one of the paper they have pathological outcome they have discussed like this: in papillary carcinoma, follicular epithelial cell, follicular adenoma, carcinoma, all can convert into the poorly differentiated thyroid cancer, and if P53 mutation present in that, it can convert into anaplastic carcinoma also. So frequency wise, we can see TERT mutation is common in poorly differentiated thyroid cancer, 40 to 50%, followed by RAS 20 to 40%, P53 20 to 30%, and BRAF 10 to 20%. And P53 is commoner in anaplastic carcinoma. So when they see in pathology or molecular basis follicular derived neoplasm, what first they see? BRAF V600E. If BRAF V600E is present, then differentiation is present or not. If differentiation is not present or poorly differentiated, then it is poorly differentiated thyroid cancer, if not an anaplastic. In another side, we can see if BRAF mutation is absent, then they have divided this in three molecular types, two molecular types and three groups. What is the group? BRAF-like, RAS-like, and non-BRAF, non-RAS like. So BRAF-like is present, then we have to see differentiation. If no BRAF-like BRAF is not present, then we have to look for RAS-like. RAS-like, they have to see encapsulated or circumscribed follicular pattern present or not, or PTC nuclei feature is present or absent. If it is absent, then we have to see invasion. Invasion, if no invasion, benign. If is questionable, then malignant potential is present or not. If malignant presentation is present, then differentiation. So finally, there are three molecular patterns of the what they have divided follicular neoplasm: BRAF-like, RAS-like, and non-BRAF-like and non-RAS-like. So BRAF-like, RAS-like, finally TERT promoter accumulation genes, which lead to the differentiated high grade, and PDTC, which is intermediate group, and finally to anaplastic thyroid cancer. Similarly, if there is a PTC nuclei is present, so they are looking for the invasion. If invasion is present, then malignant or not. Differentiation is present. The solid trabecular insular pattern. If mitotic count is more than 3 and convoluted nuclei is present, then poorly differentiated thyroid cancer. The most common driver mutations are BRAF V600E, NRAS, and TERT, and most common markers express TERT and BRAF. TRT mutation means aggressive factor indicator of RIA, radioactive iodine refractoriness. So it is important, is found increasing in the manner of PTC में it only 9%, in poorly differentiated thyroid cancer 40%, in anaplastic 73%. A strong association with PDTC Turin tumors with RAS mutation have been found, and PDTC MSK tumors, now it is changed into differentiated high grade carcinoma associated with BRAF mutation. So poorly differentiated thyroid cancer derived from the papillary thyroid cancer with BRAF mutation possesses high probability of regional nodal mets because it's more belong to PTC type, and RAS type is most belong to follicular thyroid cancer, so it's mainly more frequently distant metastasis is common in this subtype. So these are the studies which have studied molecular mutations in this poorly differentiated thyroid cancer, and they made their own conclusion. Like Duan et al., they found the BRAF mutation is common and well differentiated component are observed in 50% poorly differentiated thyroid cancer. Dicer 1 in adolescent patient, and BRAF 33%, and TERT is 40%. And BRAF mutated were smaller and higher nodal mets, and RAS mutated has larger and higher distant metastatic. So there were thyro sequence 12 gene panel they have used, or NGS pattern they have used for the analysis of molecular pattern. Now comes to the staging. This staging is common for all type of thyroid cancers, either differentiated or anaplastic. And staging, we have to know that this poorly differentiated thyroid cancer also comes under in the differentiated thyroid cancer only, and they are using under 55 years there is only 2 stages, stage 1 and stage 2, and older than 55 years there are 4 stages. This is the basic any thyroid swelling if nodule present to us, we do this routine investigation. So there should be a high or intermediate suspicion of the thyroid cancer of more than 1 centimeter size nodule, we should go for FNA, and according to Bethesda criteria we are dividing it. So what ESMO guidelines says around for the management of differentiated or poorly differentiated thyroid cancer, preoperative FNA should be done for all nodules more than 1 centimeter. All thyroid cancer except we are focusing mainly on poorly differentiated, I will focus on that only. So among aggressive histologies, what they say, poorly differentiated is the one of the aggressive histologies, and it will come into the intermediate, that is 6 to 20%, in which they have added this BRAF mutation in that an aggressive histology. So what we should do for such patients: resection of locoregional advanced thyroid cancers with the involvement of adjacent structures like larynx, esophagus, trachea, carotid vessels. Extensive, all these resections are very morbid, and shaving off and remaining residual disease should be if there is then poor survival outcome is there. So either we should do R0 resection or may consider R1 resection, but R2 resection is not all justified. And also the patients are going for surgery followed by radiotherapy or followed by RAI. In both type of treatment there is no any survival difference, and there is no any established data which have to be preferred. So for T1A, as they have given common treatment for differentiated and poorly differentiated, patient can go for thyroidectomy, lobectomy alone. But NCCN says if aggressive histology, that is poorly differentiated, is present, then patient should go for total thyroidectomy. And central lymph node resection should be done for all patients of poorly differentiated thyroid cancer, and lateral lymph node resection should be done after sampling of the central thyroid lymph node. So this is the subsequent follow-up. What they have said, if poorly differentiated thyroid cancer is there, then 6 to 12 months serum thyroglobulin and TG antibody assessment should be there, and with neck USG should be done. And other, they have said poorly differentiated thyroid cancer, in which they recommended no without any cross sectional imaging should be included. So what is the difference in these two? That is still controversial. When to do USG neck as an examination, when to do this cross sectional imaging in the follow up. Optimal management, resectable poorly differentiated thyroid cancer of course have better survival outcomes as compared to unresectable. Complete resection of primary disease and therapeutic neck resection is advisable because lymph node metastasis rate is high, 30 to 59%. And clinico-pathological trend analysis, despite of it adequate imaging, positive resection margin 19.7% is there. The surgeon should be well adapted towards partial carotid encasement, tracheoesophageal invasion, and thorough nodal clearance in poorly differentiated thyroid cancer. So according to the ATA risk stratification, it comes into the aggressive histology or vascular invasion. It comes in the intermediate group. So intermediate group, we should prefer radioactive iodine or not. It is the one of the question. So in subsequent slide we will solve that, try to solve that, but there is no definitive guidelines. So what NCCN says, कि poorly differentiated high grade carcinoma is the one of the indication of total thyroidectomy. So when to do total thyroidectomy in the thyroid patients? When extrathyroidal extension is there, lateral cervical lymph node metastasis or gross central lymph node metastasis is there, poorly differentiated and differentiated high grade carcinoma, and consider prior radiation exposure. Then also we should consider total thyroidectomy, followed by neck dissection or compartment clinically apparent biopsy proven disease. So what is the role of radioactive iodine in poorly differentiated? So there is a spectrum. In well differentiated, it is a proven that RI has a role. In ATC, we already know it has no role. So what about poorly differentiated? Because it is intermediate between that. So there is one SEER data analysis was done in 2022, which said RI treatment and patient who has not received RI, they have compared, and they revealed that radioiodine therapy was an independent favorable factor for overall survival if patient of poorly differentiated thyroid cancer responding to RAI, then it has better prognosis as compared to who are not responding, and this is statistically significant also. So reasonable to utilize iodine 131 therapy to control the distant metastasis which concentrate the iodine well. Another study, Sanders et al. Also advocated the iodine 131 therapy ought to be considered in every poorly differentiated thyroid cancer after complete surgery. Although they have some side effects of radioactive iodine, but it is justifiable. The American Thoracic Society encourages aggressive histology should receive 100 to 200 millicurie of iodine 131, including insular variants. Another study of post-operative RAI on survival impact of PDC, in which we see this blue line shows RAI and no RAI pink line, and although there its p-value is significant for overall survival, but cancer specific survival we found not that significant. But RAI has, in this study, all patients who have received RAI has better survival as compared to who have not received. And another study have done recently in 2020 in Tata. They have set 3-year progression-free survival in this study 69%, and they also shows that all patients are responding well for RAI. So what's the role of RT in poorly differentiated thyroid cancer? Adjuvant RT should be given for high-risk disease, that is after R1 resection, microscopic disease in thyroid bed or involved resected lymph node, 60 to 66 gyri in 1.8 to 2 gyri per fraction, and elective nodal region have to be addressed 50 to 56 gyri in 1.6 to 2 gyri per fraction. So Sanders et al. Suggested that EBRT should be considered in the patient tumor larger than 4 cm, extrathyroidal extension, lymph node mets, radical surgery, unresectable disease we have to give. Therefore, EBRT may be used as a palliative treatment for poorly differentiated thyroid cancer if iodine 131 treatment fails in localized tumors or like local bone mets. IMRT should be preferred because it adequately planning the target volume coverage and minimizing the dose to the spinal cord. And during this radiation therapy, there are moderate skin erythema, dry moist desquamation, mucositis of esophagus, trachea, and larynx. But they are acceptable. But after that, surgery might be difficult. So these are the study who is comparing different treatment modalities of treatment in all variety of thyroid cancer. So in this we can see operation only or operation only with ARAI or EBRT, both have equal results. There is no any survival difference in both treatment modalities. So there is a time of term that is dedifferentiated therapy, which is a seems to be the promising strategy to facilitate poorly differentiated to make him ability to get iodine 131 uptake and leads to prolonged survival. There are many strategies such as retinoic acid, peroxisome proliferator receptor gamma agonist, TKIs, and neurotrophin receptor kinase inhibitors. But all these final evidences, they are remain insufficient. No, we are not having any good result. And they have used TKI induced visible iodine only nearly 60% of the subjects, but they in after all step preparation also sustained administration of tyrosine kinase inhibitor during iodine 131 therapy is still questionable. There are many theories are there which are suggesting that we have to use many agents which can convert poorly differentiated to the dedifferentiation differentiated thyroid cancer, but result is still questionable. Finally, one study suggestive of that PDL1 or this IDO01 marker, which are the molecular markers which usually we suspect for all other cancers. In head and neck also we use frequently. What this study suggests that if patient is positive for PDL1, that is red one, have poorer survival as compared to those who are PDL1 negative. So PDL1, if treatment therapy is useful or not, they have not judged, but they have just assessed that if this molecular marker is present, then survival is lesser. So this is the flow chart how this PDL1 PD1 act on the tumor cells, and the IDOI, it decrease the activation and apoptosis and down regulation of natural killer cell receptors and decrease apoptosis. So what they found that lenvatinib can be used to obtain hemodynamic stability with the neoadjuvant intent for before thyroidectomy and RAI, and has been demonstrated safe and effective in poorly differentiated thyroid cancer, including complete and long-term remission when combined with pembrolizumab. So these are the cells. These are the many drugs which usually we use for the thyroid cancer, but among all these only one drug found to be benefit, that is lenvatinib, for managing poorly differentiated thyroid cancer. So these are the one study of Sanders et al. Which I have already discussed above. In this they have compared 3 studies, and in which they found that 5-year survival is 72% and 10-year survival was 52%, in which they have used iodine 131 plus minus RT, and this is Tong et al. Tong et al. Have done a review in which they have compared all treatment modalities for poorly differentiated thyroid cancer, and most of the studies have used Turin criteria for diagnosis, in which we can see that there is survival of 83% and 85%, which is highest among them, in which tumor size is 4 centimeter and lymph node metastasis is 51.7% in Cherkew et al. And among them, what treatment they have used: total thyroidectomy and RT and EBRT. Chemo they have used for only one study, only 8 patients, and this ZANG 2021 522 patients they have taken. They have used RT plus EBRT for their patients. So 5-year survival rate is higher if tumor size is less, that is 3.51 in this study we can see. What are the future directions for the management? FDG PET scan can be found better modality of for distant metastasis. Neoadjuvant approach can be applied, targeted therapy for locoregional advanced disease. And iodine refractory PDTC cancer, tyrosine kinase inhibitors cannot be ignored. We have to use and try therapy. Our real study, which targeted therapy should be used, is still not concluded, but lenvatinib is helpful. Thank you. Hello.
Yeah, Saumyta. Burhan, Dr. Burhan, are you there?
Yes, ma'am.
Could you take your comments?
It was a wonderful presentation. And it is important that we understand and differentiate at the time of diagnosis and even at the time of final HPR, many times when we operate these cases. So it's important to differentiate between the classical Turin's criteria and MSK criteria. So that was very nicely highlighted in the presentation. Also, just wanted to know from Saumyta that what do you do a thyroglobulin in cases of poorly differentiated thyroid carcinoma?
We usually do, sir.
Okay. In the initial workup you would do?
Not in initial workup, in follow-up, sir.
In follow-up you would. Okay, so there's limited role, but at times if you want to use it as a diagnostic adjunct, okay, maybe you can, because you can use it at times, because sometimes there's a diagnostic dilemma which may exist between anaplastic. In anaplastic, you may not have thyroglobulin raised, but you may have thyroglobulin raised in poorly differentiated thyroid cancer.
Okay, sir.
Yeah, so that is one. And also important is to note that many times when you refer the patient, although RAI, you cannot not give RAI, but essentially you have to understand, in the poorly differentiated tumor, those tumors which will only respond to RAI will be in which the MAP pathway is intact. Only in those cases your RAI will work. Okay, so otherwise then your RAI won't work. So not necessarily all cases your RAI may work, and they may be RAI refractory as well. So that is also another point which is very important. Yeah, so the mitogen activated kinase, protein kinase. Okay, so that is also the sulmitinib, and they act on that. So when you are actually dealing with the redifferentiation therapy in cases where they become RAI refractory, these are the drugs which are targeted. Okay, so That's all from my side. I think a nice presentation, and important is to diagnose these cases early, and please, surgery still remains the main treatment. And one thing again, if there is a very extensive disease as presentation, there is an increasing trend that we include them along with the trials of anaplastic carcinoma, and please get a BRAF V600 as an emergency. Okay, so could you tell me how do they do this BRAF V600E?
NGS ज़्यादा नहीं.
Direct NGS. NGS.
और thyroid 12 gene thyro sequencing.
What to do? Thyroseq 3. Okay.
12.
But so that would be how generally how is it done? We can do it on, as you said, you can do it along, but Thyroseq T is again a limited gene panel, which is actually done on these slides. But what is this exactly? BRAF V600E.
Don't know, sir.
Okay, so basically it can be done on immunohistochemistry. Okay, so BRAF V600E can be done on IHC. Okay, so you can put an IHC for BRAF V600E and you can get that BRAF V600E diagnosis. Okay, first, if it is, as you had shown in one of the charts, that if it is not there, not the classic BRAF V600E and it is another mutation, then you may do NGS, or you may do a limited panel of TERT promoter and KRAS and RAS HRAS, along with other other gene mutation, limited comprehensive genomic panel. Okay, so it's important to know how each of these tests will be done and what tissue it can be performed on. So any doubts, anybody, or ma'am, if you would like to.
Yes, yeah, Dr. Buran, I think the very important points made by you. And Saumyta, quite comprehensive. So just about, like you very rightly pointed out a couple of times, that poorly differentiated is actually an intermediate as far as its outcomes is concerned between well differentiated and anaplastic. Now, how you show that the 10-year survival of poorly differentiated, none of them survived at the end of 10 years, right? So what are the pointers pre-operatively that you would look at for surgical decision making in patients who fulfill the Turin's criteria on FNAC?
Ma'am, size, lymph node metastasis, and
size and lymph node metastasis, you even see it in papillary cancer. We are talking about specific pointers. I think Puran also wanted to, also was taking you towards it, but I think.
BRAF,
so
that
what?
thyroglobulin.
Yes.
Sorry, go ahead. Come again. So let's not go into molecular. I think Dr. Puran was quite elaborate on that. Any other quick pointers? Yeah, thyroglobulin you mentioned. So what about thyroglobulin? Generally, you do not do pre-operatively, no?
Yes.
So why, if at all, why would you consider it poorly differentiated?
If thyroglobulin is raised, if it is high, then most probably patient is poorly differentiated, not anaplastic, and other thing, it might respond with radioiodine in future.
Perfect. So if there's a poorly differentiated with maybe lung metastasis on your imaging, one way of looking at whether surgery in such patients would be justified is by some pre-operative pointers. One, you said thyroglobulin. Anything else? You made a mention of it in your presentation, but I just want your thought process to be consolidated.
Adjacent organ involved.
Yeah, I mean, of course, you will have to look at whether, in poorly differentiated, again, because of poorer iodine avidity, you would avoid morbid surgeries, like surgeries which require pharyngectomy, esophagectomy, are not considered, are not recommended. Also, like you very rightly pointed out, R2 resections, if you feel pre-operatively that R2 resection is a possibility, one must refrain from performing a surgery of that nature. But yeah, let's stick to some pointers. You said thyroglobulin. Anything else which would give you an understanding as to whether embarking upon a locally advanced surgery in that patient is justified or not? You spoke about some flip-flop phenomena, na?
Yes, ma'am.
PET-CT.
PET scan.
Yeah.
Sodium iodine
So,
importer.
correct. Yeah. So also post-operatively, all these patients would be subjected to radioactive iodine, right?
Yes, ma'am. Because of intermediate.
Although there is no evidence to show that radioactive iodine actually benefits, but you would, still subject because of its intermediate behavior. Intermediate as in it could still have some well-differentiated components.
Yes.
Yeah.
Yes.
Like Dr. Burhan was making a mention of the MAP pathway being intact. Yeah. Like the sodium iodide importer being intact in a part of poorly differentiated. But why does it not translate into improved survival? As in of all the poorly differentiated thyroid cancers, the ones who receive radioactive iodine vis-a-vis the ones who do not receive radioactive iodine, there is no improvement or there is no significant difference in survival. Why?
Why? Don't know, ma'am. Why?
No, so again,
looking like
RAI,
RAI responsive patients should do well, but why not they are doing?
correct. So these patients we are talking about a proven poorly differentiated thyroid cancers. So even if RAI acts on these cancers, they will act on the good component, and it is the bad component which will actually result into their fatality. Yeah. So regardless of whether RAI is given or not, that it doesn't really translate into improved survival. Having said that, RAI is given in all patients because even if they have a significant amount of well differentiated, rather than not giving it all. You understood, or am I confusing everybody?
Some differentiated component will act, and at least it will respond in RAI, that I can.
Correct. And yeah, are there any guidelines on poorly differentiated?
Exactly, there's no separate guidelines, but
There are no separate guidelines. Yeah, yes, there are no separate guidelines. ESMO what?
ESMO have just given ki all differentiated thyroid cancer, they have kept poorly differentiated thyroid cancer in their guidelines.
But that's what. So they have included that in the spectrum of follicular derived thyroid cancers. It's not a separate, like, as opposed to anaplastic thyroid cancers, which has a total, I mean, ATA has dedicated an anaplastic thyroid
A
cancer
separate
guideline
entity.
section. Correct. I guess that's about it from my end as well. If there are no further questions, Dr. Burhan?
Yes, ma'am. It was a lovely discussion. And Dr. Saumyta, like if you have to give radioactive iodine, and now that you know that in the guidelines also you see treat with more than 100 millicurie. So where do you get this high dose available in India?
In India, we are sending our patient for government setup RML or AIMS Delhi.
Okay.
It's not available in Patna.
It is not available. So I do not know whether does Mahavir have facility to give high dose radioactive iodine?
Mahavir have scanning facility at present, sir.
Only scanning facility.
But RAI we are also referring to. I am referring to Lucknow and Kolkata. If patient insists, then AIMS Delhi.
Okay. Great. Thank you everyone. Ma'am, shall we conclude?
Yes, I think so. Good discussion.
Thank you.
Thank you,
Thank
ma'am.
you, everyone.
Thank you, sir.
Thank you.
सिस्टर अब क्लास के टाइम पे सिस्टर क्लास चल रहा है 10 बार फ़ोन लगा रहा है उसी टाइम बोलो क्या बोल रहा है कौन है अनिल कुमार कौन है वो मुझे हाँ FJ बन गया अच्छा हाँ वो लड़का यंग लड़का हाँ एक उसको कैल्शियम ग्लूकोनेट दो MgSO4 दो ठीक है और पैन 40 और पेरिनोम दो एमसेट दो ठीक है